Thank you, Dr. Satyavani, and a very good evening to one and all who has tuned into today's meeting. Now, humans are literally what our muscles make us, because there are more than 400 skeletal muscles which make up about 40% of our body mass and occupy about 75% of all the cells that are there in the human body. But strangely enough, when we talk of failure of different organs, we talk of failure of the heart, we talk of failure of the kidneys, failure of the liver, we rarely talk about failure of muscles, because sarcopenia literally is a condition where your muscles are failing, where there is a poverty of flesh, if you translate it from Greek in toto. So the reason why sarcopenia is not discussed often, the reason why it's underlooked, overlooked, under-recognized is possibly because measuring sarcopenia has been difficult. And as the saying goes, if you cannot measure it, you cannot improve it. However, there is a formal definition of sarcopenia, an operational definition from 2010 onwards, which says that if you have low muscle strength, you probably have sarcopenia. On top of that, if your muscle quantity or quality is low, you have confirmed sarcopenia. So earlier it was only a decrease in muscle quantity. Nowadays, preference has been given, the first preference is given to a decrease in muscle strength, followed by a decrease in muscle quantity and quality to say that you have confirmed sarcopenia. And of course, if you have low physical performance as a whole because of these factors, you are set to have severe sarcopenia. The moment we talk of sarcopenia, what flashes in front of our eyes is the elderly, frail-looking Indian. It could be a male or a female. But interestingly, it's not only the elderly who are affected by sarcopenia in India. Our colleagues from PGI Chandigarh published the SarcoCube study in around 800 community-dwelling individuals from Chandigarh, aged 20 years and upwards, and the mean age of these 800 individuals was only about 44 years. And they found that using Indian cutoffs, not using European cutoffs, which would have given even greater prevalence, using our data, about 3% of individuals had sarcopenia, even middle-aged to young individual, it was a big cohort, and 2% of the overall cohort with a mean age of 44 had severe sarcopenia. Down south from Thiruvananthapuram, last year there was publication of a hospital-based study where individuals who underwent an abdominal CT, the investigators also looked at the lumbar muscle mass and found that 50% of hospitalized patients or in-hospital patients had sarcopenia. And there are studies published from elsewhere which have shown that in hospitalized patients, about half of these patients have sarcopenia. Overall, if you look at sarcopenia, the older you get, the more you get prevalence of sarcopenia. But the Chandigarh study raises eyebrows. It brings to light the fact that even at younger ages in India, there could be a lot of sarcopenia. So yes, there could be a lot of sarcopenia in India. Why should we be concerned? There are several things which are prevalent in India. Some of these do not hurt. But sarcopenia actually does hurt because it leads to increased morbidity, reduced locomotion, increased falls and fractures, and most importantly, it increases the risk of death by as much as 3.5 times compared to individuals who do not have sarcopenia. So what leads to sarcopenia? So again, if it is a gradual onset loss of muscle mass and muscle weakness without any specific cause in the elderly, it is what is known as primary sarcopenia. And this primary sarcopenia is a disease by itself as per the International Classification of Diseases from 2016. So it's a primary disease by itself. There are secondary causes of sarcopenia which are related to chronic diseases, which directly or indirectly lead to altered nutritional status and altered muscle mass, or lead to sedentary behavior or restricted locomotion, leading to altered muscle mass and activity. Now, we were discussing frailty in the previous lecture. If you look at frailty as a whole, it's a much bigger concept. Overall, general frailty is what ails most of our elderly. Sarcopenia is only a small part of general frailty. However, physical frailty and sarcopenia are not necessarily the same, although there is a big overlap between physical frailty and sarcopenia. Now in India, when you have a lot of undernutrition, malnutrition, the question automatically arises, is malnutrition the same as sarcopenia? To an extent, yes, but there are significant differences as well, because in patients with malnutrition, you have a decrease in fat mass as well. Whereas in sarcopenia, fat is not necessarily decreased, it can be increased in what is known as sarcopenic obesity. Additionally, in patients with malnutrition, although there's a decrease in muscle mass, muscle weakness might not necessarily be there. Whereas in sarcopenia, there's a decrease in both muscle mass as well as muscle weakness. So it's a disease by itself. Of course, there are a variety of factors which lead to sarcopenia, but some of the important risk factors include our sedentary lifestyle. We have an evolutionary mismatch as well, because the genes regulating our muscle mass and function are genes which are with us from the late Paleolithic period, when there was greater obligatory muscle use, and we are more sedentary now compared to our ancestors. With aging, again, there is a decrease in hormones like testosterone, insulin like growth factor, thyroid hormones, increase in catabolic factors like interleukin 6, TNF alpha. There's decreased protein synthesis, reduced motor unit remodeling. Most importantly, in a country like India, what is important is early developmental influences. This is because low body weight at birth or low birth weight is related to a much greater risk of sarcopenia, and this risk persists throughout the lifetime of an individual. So the million-dollar question, since sarcopenia is under-recognized, we need an active approach, a case-finding approach. In whom do we screen for sarcopenia? We do it in any patient, irrespective of age, who complains of increased falls, decreased locomotion. It could be difficulty in rising from a chair, climbing up the stairs, difficulty in walking, or who complains of generalized weakness without any other obvious cause. And of course, if it's the elderly, you need to keep your antennas up to screen for sarcopenia even more often. Now, how do you screen for sarcopenia? You have a questionnaire called the SARC-F questionnaire, where S stands for strength, A for assistance in walking, R for rising from a chair, C for climbing stairs, and F for falls. And for each of these parameters, you have a score of between 0 to 2, where 0 is the best possible score and 2 is the worst possible score. You add up these 5 parameter scores and you get a score of 0 to 3 in healthy individuals and 4 to 10 in unhealthy or sort of sarcopenic individuals, where 10 being the worst possible score and 0 being the best possible score. Now, this SARC-F questionnaire has moderate sensitivity but reasonably high specificity. And since it's a self-reported questionnaire, adverse effects perceived by the patients are picked up, which is very important because it's related to their quality of life as well. Now, if once you have administered the SARC-F questionnaire, the next step is to objectively assess muscle strength. Now, again, there are authorities who say that you can directly go to objectively assessing muscle strength without administering the SARC-F questionnaire if you have the logistics for doing so. To assess muscle strength, the commonly used test is using a Jammer dynamometer, which is sort of the gold standard for assessing hand grip strength. And if you have a hand grip strength of less than 26 kgs for Asian men and less than 18 kgs for Asian women, you are said to have decreased muscle strength. Now, if you have arthritis affecting the hand, or if you have sort of a weakness of the hands for some reason, you can look at lower leg strength as well. And one of the tests to look for lower leg strength is the rising from the chair test, where you rise for 5 consecutive times without using your arms. Your arms are crossed against your chest so that you do not use them for support. And if you take more than 15 seconds to rise from your chair for 5 consecutive times, it denotes weakness of the muscles, weakness predominantly of the quadriceps femoris. So these are the 2 tests which can help assess muscle strength. Now, once you have shown that your muscle strength is low, you can go on to confirm loss of muscle mass or quality to stamp the diagnosis of sarcopenia from probable sarcopenia to confirmed sarcopenia. CT scans and MRIs have been tried, but again, there are no validated cutoffs. DEXA has been tried, and in Asians, appendicular skeletal muscle mass divided by height square of less than 7 in men and less than 5.4 in women denote a decrease in muscle quantity. Again, when you are using a per meter square height correction, you take care of the body weight, the body size, because Caucasians, by virtue of their larger body size, have overall increased muscle mass as well. Now, bioimpedance analysis can also be used to denote a decrease in muscle mass. It's more easily available, it's much more economical to use, and there are validated cutoffs in Asian males and Asian females to denote decreased muscle mass using bioimpedance analysis as well. Now, once you have confirmed your diagnosis of sarcopenia, the next step is to determine whether you have severe sarcopenia or not, because the more severe the sarcopenia, the worse the overall prognosis. And physical performance is an overall objective performance of parameters related to locomotion. So you can look at the gait speed, where the individual walks along a 4 to 10 meter section using a stopwatch. And if your gait speed is less than or equal to 0.8 meters per second, you have severe sarcopenia. Or you could do a battery of 3 tests looking at balance, speed, and the chair rising test, called the short physical performance battery. A total score of highest 12 can be attained in this SPPB. A score of less than or equal to 8 denotes the presence of severe sarcopenia. The other test which can be done is the 400-meter walk test, where there's a 20-meter stretch. The individual walks as fast as he or she can over these 20 meters in a circular fashion, sort of a straight line, turns around and then comes back again. And the individual is allowed 2 rests in the 20 laps that he or she takes, 2 periods of rest. Anyone taking 6 or more minutes for completion is said to have severe sarcopenia. The easiest possibly of these tests, which requires the minimum space and minimum equipment, is the so-called TUG test, or timed up and go test, where the individual stands up from a chair, walks 3 meters forward, turns around, walks back 3 meters and sits in the chair. And anyone taking 20 seconds or greater is said to have poor physical performance or severe sarcopenia. Again, there are a number of other tools which have used ultrasonography, CT scan, MRI, biochemical parameters to assess for sarcopenia. However, none of these are validated, and these are most likely to be used in research settings. Now, having recognized the phenotype, we need to have some idea of how to treat the phenotype. Frankly speaking, nutritional interventions without exercise, which have looked at sarcopenia treatment, are lacking. However, low quality evidence, observational evidence suggests that there could be some benefit by giving adequate proteins, adequate vitamin D, adequate antioxidant nutrients, and adequate long-chain polyunsaturated fatty acids. In terms of exercise, again, the individual trials looking at sarcopenia are small, and they have not been validated in terms of looking at the specific type of exercise or the specific duration of exercise or the pattern of exercise. But systematic reviews and meta-analysis suggest that resistance training and strength training could help elderly individuals with sarcopenia to improve both their muscle mass as well as muscle strength, and bring about a salutary effect on the hormones and cytokines which bring about sarcopenia. In terms of pharmacologic therapy for sarcopenia, interestingly, the global market is huge. It runs into billions and is projected to grow exponentially over the next decade. However, in terms of drugs which work actually, the only evidence is limited to use of vitamin D, particularly in women with deficient vitamin D levels, in whom vitamin D increases both the muscle mass as well as muscle function. In men with low testosterone levels, lower than 200 nanograms per deciliter, testosterone supplementation could help improve muscle mass with a minimal to modest effect in improving muscle strength. So out of all drugs which have been tested, vitamin D in vitamin D deficient women and testosterone in hypogonadal men could have some beneficial effect. Of course, there are a host of experimental therapies like selective androgen receptor modulators, which have anabolic activity but no androgenic activity. Myostatin antibodies, again, these are all in phase 1, phase 2. They haven't been actually successful enough to come into a phase 3 trial. And the World Anti-Doping Agency has banned the use of both SARMs as well as myostatin antibodies in athletes. Ghrelin increases appetite, increases lean body mass. An anabolic catabolic transforming agent reduces fat mass, increases muscle mass. But again, these are under investigation. A monoclonal antibody is under development by Novartis, who have possibly progressed quite a bit in developing the molecule, and they are pining on it, they are hoping on it for the future, called bimagrumab, which is a monoclonal antibody against the myostatin activin type 2 receptor in the muscle, inhibition of which leads to increased myocyte proliferation. And of course, rapamycin or sirolimus, the mTORC1 inhibitor, has some role in improving muscle mass as well. Now, once we use a good diet, a protein-rich diet, vitamin D supplementation in those who are deficient, using testosterone in males who are deficient, giving individuals a healthy diet which is rich in long-chain polyunsaturated fatty acids, asking them to go for resistance training and strength training, how do you monitor effectiveness of therapy? The two parameters which have been validated are an increase in gait speed by more than 0.1 meter per second and an increase in the SPPB score, the battery of 3 test score, by at least 1 point. The quality of life questionnaire for sarcopenia is something which is in the process of being validated to test the effectiveness of therapy. But again, since it is a patient-reported outcome, it could have some significance. So as sarcopenia is underreported and under-recognized, and the main reason for it being underreported and under-recognized is the fact that we often are confused as how to measure sarcopenia. The most important message from today's presentation would be to actively look for sarcopenia. We need to find cases, ask for patients' symptoms, use a screening questionnaire, the SARCF questionnaire, assess for muscle strength, confirm a decrease in muscle quantity or quality, and look for altered physical performance to denote severe sarcopenia. And again, if all these appear too complicated or too time-taking for your busy OPD practice, you can have a simple 2-minute sarcopenic testing. Again, this is not something which is validated, but this is something which is based on sound evidence. In patients who complain of weakness, increased falls, difficulty in climbing stairs, difficulty in walking, you can do a basic chair stand test where the patient rises consecutively for 5 times. If it takes more than 15 seconds, you have probable sarcopenia. If you do not have access to a DEXA scan or a bioimpedance analysis instrument, you can simply look at the calf circumference, which is a good surrogate for a decrease in muscle mass. The patient keeps the leg at 90 degrees perpendicular to the ground. Using a measuring tape, you measure the calf at its maximum width. Anything less than 31 centimeters denotes a decrease in muscle mass. And when you have confirmed sarcopenia, you can do the simple timed up and go test. You just need 3 meters of space and a chair to do the test. And if the individual takes more than or equal to 20 seconds, you have severe sarcopenia. So using a simple screening method, you can help pick up more sarcopenia. But I think when it comes to sarcopenia, again, since there is no definite therapy of sarcopenia, yes, a healthy diet, exercise could be helpful, but overall, since there is still no specific pharmacologic treatment for overall sarcopenia, prevention would be better than cure, and prevention would begin right before birth, because as I said, developmental problems, low birth weight leads to a lifelong increased risk for sarcopenia. So improving nutrition in antenatal mother, improving nutrition in children, asking children to be physically active from a young age, because you attain a peak muscle mass at around 40 years of age, you need to keep exercising throughout your lifetime. After the age of 50, there is a physiologic decrease in muscle mass as well as muscle strength, and you need to be more cautious to maintain your peak and you minimize loss. And I think that when we talk of prevention is better than cure, the best possible inspiration could come from closer at home. From Kolkata, we have an individual called Mr. Monohar Ait, who happens to be known as the father of bodybuilding in India. At the age of 40 years, as you can see on your left, he was crowned Mr. Universe, the second Indian to be crowned Mr. Universe. He lived till the ripe age of 104 years, and on the image on your right was taken on his 100th birthday. He was 100 years of old when this image was taken. Again, I think Mr. Eich is, of course, an aberration, an exception. You do not need to be as good as Mr. Eich, but yes, we need to be aware that sarcopenia exists and we need to adopt a healthy lifestyle, exercise regularly to better deal with sarcopenia, since there's no specific pharmacologic treatment to deal with the same at present. So I end my part here and hand it back to the organizers.
Thank you so much, Dr. Soumik. That was a very elaborate, comprehensive, and a wonderful talk.